Good evening, everyone, and welcome to Gyan Pravah podcast series number 310. Gyan Pravah, which has been the flow of knowledge. It has started from the 29th of January and has reached its 310th episode. And I, Dr. Sita Ramamurthy Pal, chairperson of the Genetics and Fetal Medicine Committee, Fogsi, is going to be the host today. Gyan Pravah, as the word says, it is basically ज्ञान का बहता रोजाना एक नया अनोखा रंग हर रात 8 बजे जुड़िए आप Foxy के संग. So every night at 8 p.m. one committee chairperson comes up with a podcast diligently every night with a different topic of their interest and brings forward any medical, non-medical, political, spiritual guest speakers who are masters in their own subject, and this has been the wonderful and unique initiative of our visionary president, Dr. Sunita Tandulwadkar. And this has been going incessantly, brilliantly, successfully, and we have learned so much through this process. So thank you, madam, for this initiative and for this opportunity. Thank you. And we welcome our guest speaker for today, Dr. Asha Singhani, who's a pioneer and an expert in maternal fetal medicine from the USA. Thank you for joining us today. Thank you.
Before we start, very much. Thank you to Dr. Sunita and to Dr. Sita.
Thank you. Before we start, I'd like to say a small introduction. I mean, the words are not enough to express the passion that Dr. Sunita Tandulwadkar has, our dear own president. She's the current president of Fogsi. She's a leading laparoscopic surgeon and IVF specialist and has done pioneering work in stem cell therapy. But more importantly for Fogsi, for the women of India, this year she has pioneered so many projects which has touched the lives of each and every woman across India, across all the societies. And some of her key projects are this Gyan Pravah podcast series, her Sampurna project, which has touched the woman, which is looking at the woman holistically, preconceptionally, till she delivers and much beyond after that as well. And each project carries with us enormous capacity to empower women, to educate women, to make them self-sufficient and make them health aware, which brings them all the things that they need to know about themselves. And more importantly than that, there is this Arogya Yog Yatra, which is the spiritual journey we've all embarked upon. And this has enlightened all Foxians through this journey of combining spirituality with medicine and her do TK Zindagi Ke.
Sita, thank you so much.
So, I mean, as I said, words are not enough. But this has been a beautiful year, a power-packed year with our power-packed president, Dr. Sunita Tandulwadkar.
Thank you, Sita. Thank you so much for your kind and lovely words. And I could do even whatever we have done is only because I'm supported by these 30 commanders. The committee chairperson, they are so fantastic, so dedicated and committed, and each one is full with the energy and passion to work. They just need a push and they just work. Sita, your podcast series, if you combine all these series, it will be one of the best fetal medicine workshop of a day. I think we all have to sit and brainstorm what we should do with this 310. I'm sure we will be touching now another 30 days, 35 days to so 350 episodes, and few of you have taken only academics, and that is also fantastic because every time you chosen the faculty of that level, Sita, you yourself are so deeply involved with your subject that automatically your podcast has become a great learning experience. I think we all should brainstorm and probably not combining all 350 together, but combining the subject wise, like your own 11 podcast. All I still remember means you have chosen all the best faculty in the world and in the city, in the country. So we should brainstorm. And thank you, Sita, for your passion, for hard working. And you know what, Ashaji? Our Arogya Yog Yatra was one of the beautiful spiritual journey. India is full of beautiful places, like from Puri to Rishikesh to Rameshwar to Tirupati. Everything is different. And now we are reaching to Ayodhya in December. 8th and 9th is in Ayodhya. We have Amritsar and Dwarka yet to cover. So it's a beautiful journey, taking the blessings of the God to help us, to help our women is one part, but also enlightening in the minds of our Foxian, that just allow spirituality, allow the universal power to come through your hands, and you see miracles happening in your clinic. So it's a beautiful journey, and Sita is one of the spiritual person who traveled many places, and we had a great moments, lifelong. Those memories will remain with us, and anytime we'll revisit, we'll remember 2025 again.
Absolutely. It has been a very memorable year. And I must acknowledge Dr. Sunita here that, for every podcast, she makes it a point to join wherever she's from, be it early in the morning or from the flight or from a program that she's attending or a meeting. She does. And so, really, thank you for your passion. And that inspires all of us to go forward in life. Thank you.
Thank you, thank you. It was, it's a beautiful thinking, that 310th episode today, because when we designed this podcast, we were thinking, ki, is it possible 8 p.m. every day? It's more than me, my chairperson. They need to be very much passionate about the project, and they should be selecting the best faculty, talking to them, taking their interview. Some people like environment or violence against women, the same topic with the different faculty, whether they will be able to carry those, but beautifully everyone has done it. So I'm thankful, and our pattern is Ashaji. I'll be joining from the viewers link to listen to both of you. It will be a beautiful dialogue between Sita and Asha, and I'm sure today, because of your timings, we have done the reverse way. We are pre-shooting, but that is better than you getting up at 6 o'clock. It's better me getting up at 6 o'clock and shooting you at 9 p.m. at your place. Thank you so much, and thank you for coming on a Foxy platform. I joined just to show my respect to the faculty who has taken out their valuable time for Foxy for this podcast. Thank you so much, Sita, for having such a lovely faculty. Thank
Thank
you.
you. Thank you.
It's wonderful, Dr. Sunita, I can't believe you've done so much. It's amazing, brilliant. And I wish I was there because I like to go to all these places, and I'm hoping to do it next year. All these
Okay.
Tirth Yatra.
So, for your information, Asha ji, Bhaskar Pal, Sita's better half. I don't want to say better half. Sita is a better half. But anyway, because Sita, see, I have worked with Bhaskar, but I have worked with Sita also. Uh, he is taking over as a president. So you pursue him. Who never will enter the mandir. Sita is the one who compensates for both of them. So we will start the parallel journey.
Yes,
We will pull him because I go to every possible place I can.
I'm continuing this in a Isar, but not so passionately like all the month, but I'm continuing this in Isar because our places are not yet over. So remaining places, I'm taking over as a president of Isar, so we'll continue over there. Let's have it.
yes, we can
Okay.
Let me know it. I'll join you.
Yeah. Thank you. Have a
Thank
best
you
of the
so much.
dialogue.
Thank you.
Thank you.
Thank
Thank you
Thank you.
so much. Thank you, Dr. Sunita. Thank you. So tonight we have our eminent guest speaker, Dr. Asha Ridsinghani from the US, and our topic of discussion today is decoding stillbirths, where we delve a lot into vasa previa, which is one of the dreaded problems causing stillbirth. But before we start our conversation, I'd like to to introduce our esteemed guest speaker, Dr. Asha Singhani, who is the maternal fetal medicine professor at the University of Washington, professor emeritus, University of Iowa, USA, and she has been the co-founder of the Society of Maternal and Fetal Medicine USA India chapter since its inception 2019. She is currently affiliated with the University of Washington, USA, University of Iowa, USA, Morristown Medical Center, USA. She has been part of the fellowship training and faculty at the Johns Hopkins Hospital, faculty Johns Hopkins Hospital, and also been the tenured professor of the University of Iowa, University of Washington. She has multiple awards to her credits, the APGO, the Teacher of the Year, the Best Doctors of America, and the US Top Doctors. She has a number of publications in index journals, over more than 100 publications to her credit, and many book chapters, guest editors, as well as contributors to many books. She has done a lot of work in the field of preeclampsia, eclampsia, obstetric cholestasis, and which all are part of, causing stillbirths. And today we are going to be talking on a very important subject of stillbirth, because stillbirth is such a heavy word, and it's not a word that causes just carries an enormous weight, a weight so heavy that it has been spoken only in whispers among our population. And here today we take a very compassionate approach, an evidence-based approach at the area, and we look at most of the most misunderstood part of stillbirth and less often overlooked areas of pregnancy. And we're going to be talking about the different aspects of stillbirth, and especially vasa previa, which is something very, very underspoken, under-recognized, and and that contributes a lot to our causes of stillbirth in India and across the country. So welcome, Dr. Asha Singhani, and thank you once again for being part of this podcast. Thank you.
Thank you. Thank you very much for inviting me. And thanks to all those that are watching and listening. It's a pleasure. My heart is in India and I keep coming to India. And I've seen India change dramatically. When I started coming and giving talks, there were very, very few people interested in maternal and fetal medicine. And
Yes.
now a whole new generation is interested. And it's just growing by leaps and bounds. And it's so wonderful to see that. So
Absolutely.
I'm so glad that I can be a small part of this big movement in India.
Thank you.
It really gives me great pleasure. So I'm very grateful to you, Dr. Sita, for inviting me.
Thank you. And I must say that you are part of us, because your medical schooling was in India. You are, and you visited us with so many occasions. So we feel you are part of us as always. So thank you once again for being part of this Fogsi initiative. So when we start talking about stillbirths, what exactly right now are we saying is the medical definition, and why does it vary between countries? I mean, and some people get actually confused about when exactly they need to specify. So can you just brief us about what is the current and how does it vary between the US and India, and why does it vary so much?
So, the thing is, there are some good publications asking the exact same question, that why is the stillbirth defined differently in different countries? And so WHO has a different definition, USA has a different definition, European Union has a different definition, and within the European Union, the definitions are different. And so how come we have so many different definitions? And one of the things that is published is that stillbirth means death before expulsion of the fetus, the product of conception. And so one of the reasons different gestational ages are used is because of the care that can be provided by the specific country, and the gestational age at which a fetus is considered to potentially survive outside the mother's womb. Yeah. They pick that gestational age. So in the US now, they have some of the 22-week fetuses are being
Salvage.
resuscitated after birth. They're getting steroids and resuscitated. That would never happen in India. And I don't know, I mean, it's a big ethical question. Why do we use 22 weeks? Because many of these babies won't make it, and those that make it have a lot of brain damage. But anyway, USA actually uses 20 weeks or 350 grams. European Union uses 22 up to 28 weeks. Different countries different. And WHO uses 28 weeks. And I think so India uses the 28 weeks as defined by WHO.
Yeah. But having said that, with the advances in neonatal care and a lot of things coming up, people are, especially if the family wants, I mean, we are no one to decide. If the family wants, if the baby's born, they want to go all their way to, salvage these babies and do whatever is possible, having been explained all the risks and potential problems that the baby might have. But regarding stillbirth, I mean, it's such a traumatic experience for the entire care, for the patient, the family, the caregivers, the staff, the doctors. I mean, it's something that we never forget if such an episode happens. So with advances in ultrasound and fetal monitoring that has come, do you think fetal monitoring technology has changed the way we can detect this? How good are we now in predicting, or how bad are we still in predicting the same, be it any condition for that matter? Yeah.
Yeah. So, ultrasound, as you know, and you are such an expert at ultrasound, it has helped us detect conditions that are lethal. And so it helps us counsel the patient and let her know that chances of a stillbirth is maybe even 100% with an anencephalic, or maybe not quite 100%, but greater than 90, and maybe those that will come out will die. So perinatal death is 100%. But in terms of fetal heart rate monitoring, it was introduced many decades ago. Antenatal fetal heart rate monitoring, as well as intrapartum fetal heart rate monitoring. Intrapartum fetal heart rate monitoring has been questioned for increasing the cesarean section rates in the Western countries. But both of these actually have been found to help when you look at it worldwide. Antenatal testing in the high-risk pregnancy group definitely has reduced the risk of stillbirth. It's well documented. So when you start doing antenatal testing based on growth restriction on ultrasound, or even if there's no growth restriction, patient with lupus, severe hypertension, severe diabetes, where there is no growth restriction, antenatal testing once or twice a week or thrice a week, if it's a very, very high-risk situation, will tell you when to deliver. And many of these patients will deliver prematurely because you have detected fetal decompensation. Intrapartum in the US, all patients are monitored continuously all the time during labor. That is sort of the standard of care. And many doctors are quick to do cesareans if they see a little deceleration. So intrapartum monitoring has received some bad, some bad publicity, that too many people are being sectioned unnecessarily. But there's no question that intrapartum fetal heart rate monitoring has helped reduce the stillbirth rate. And if you look at stillbirths, if you look at the whole literature, 40% of stillbirths occur during labor. So 40% are intrapartum. So when you continuously monitor the patient, the fetus in labor, you can potentially prevent all of these intrapartum stillbirths. Sure, if you know ahead of time the fetus has trisomy 13 or trisomy 18, you will not be doing continuous monitoring. But at least you may want to monitor every hour to see if the baby is alive, so that when the baby is delivered, parents and the pediatricians know what to anticipate. So intrapartum fetal heart rate monitoring continuously has helped reduce intrapartum stillbirths.
And as you said,
And 70% of stillbirths occur actually in high-risk patients.
pregnancy.
So there's no question that the high-risk patients are monitored continuously throughout the labor.
And I
Sorry,
think
Dr.
even if,
Sunita.
even if the numbers needed to prevent may not be that high, I don't think it is worth the effort to take to monitor all these pregnancies intrapartum, because at the long run nobody will question you as to why you did it. But if you didn't do it and lost had a stillbirth, that would be even worse. So I think it's better used than not. So, in terms of decoding stillbirth, as our podcast title is, we are looking at how the different causes are, and we know of the very common causes in terms of diabetes, uncontrolled, or hypertensive disorders with severe hypertensive. But one of the leading or upcoming unrecognized causes as something called vasa previa, which we'll be discussing about. So I just wanted you to tell our viewers, and because this is going to be viewed not only by obstetricians, but also by non-medical professional people who might not know what exactly is this, or they might have had a person or family member who's had stillbirth and may not realize. Most of these stillbirths are sort of unexplained, as we call it, and we don't realize what they are. And the only question the family wants to know is, will it happen again? And how scared, how apprehensive they are before they embark on a pregnancy. So what is this vasa previa, and how would you explain in simple terms to a layperson, or even for that matter, an obstetrician?
Yeah, that's actually, you put it so nicely that the stillbirths that occur due to unknown etiology, how do we know it was vasa previa? Unless somebody is actually looking at the membranes and at the placenta and at the blood vessels that are close to the cervix, you would never know it was vasa previa. And one of the doctors where I work, Dr. Ulesi, he's sort of, he is a vasa previa guy. And so he was saying that they had a case of a vasa previa and pretty complicated. And they send the placenta. He takes pictures of the vasa previas, and actually I have lots of those pictures too. But he takes pictures.
Well, Yinka Ulesi, yes, yeah.
Yeah, and so, it was very obvious patient was delivered via cesarean time delivery. And when they send the placenta to pathology, pathologist called it placenta. That's it. So they do not necessarily look at membranes and look for vasa previa. So a pathologist can very easily miss it because they are not used to looking at it. An obstetrician can very easily miss it if after the stillbirth and after the baby has come out, they don't look at the placenta and the membranes. An ultrasound doctor can easily miss it antenatally if they are not looking for it. And, there is currently, it has changed in the United States, but even 15 years ago, there was no standard of care of how to diagnose.
Just tell us what vasa previa is and how will you say it?
Oh, absolutely. And before I go to what a vasa previa is, I just want to mention one line about fetal heart rate monitoring, because all the obstetricians monitor. In the US, you have to take an exam every year to be certified that you know what you're reading. And unless you know how to read fetal heart rate monitoring, you're not allowed to cover labor and delivery. And this test is given every year. It's a national test. So somebody who's doing fetal heart rate monitoring better know how to monitor the heartbeat and how to interpret it and not to do unnecessary cesarean. Same way. When you see vasa previa, you have to know what it is. Otherwise, how can you make a diagnosis? So just like placenta previa, placenta is on top of the internal os. Vasa previa is a blood vessel, fetal blood vessel on top of the internal os. So it's in the membrane. It is not, there is no Wharton's jelly, there's no placenta around. It's just a sort of a naked blood vessel running through the membrane on top of the cervix, internal os. And if you break the water or if the patient has spontaneous rupture of membranes, you could potentially tear that blood vessel, and she may bleed 1 or 2 ounces, which is nothing for a laboring patient. But for a fetus, 2 ounces is a lot of blood, and that baby has a very, very high risk of death. In fact, undiagnosed vasa previa babies, about one in, if you look at prior to us, now we are doing regular screening, but prior to that, close to 60% of the undiagnosed vasa previa babies died during delivery, during labor and delivery with rupture of membranes. Now it is less than 5%, way below 5%, but it's about 60% if undiagnosed. And if you look at all stillbirths, 3% of all stillbirths are due to vasa previa. So it makes a big chunk. And if you look at the number of deliveries in India, about close to 25 million births in India each year, there are about 15, if you don't diagnose it, you can have 15,000 stillbirths related to vasa previa, because 3% of all the stillbirths will be due to vasa previa. And so it comes to about 15,000 deaths per year due to vasa
That's a
previa if
significant number,
undiagnosed.
yeah.
Huge,
Yes, that's
yeah.
a significant number, yeah. And
Yeah.
especially with the rising number of cesareans, do you think that increases the incidence of this vasa previa, or how common is it? We do know how dangerous it is, because as you said, the baby can exsanguinate. But how common is it, especially when we look at our ladies having more previous cesareans? Is it the same as placenta creta spectrum, or does it differ?
No, this is just a little fluke. You know, the blood vessel found its way in the membranes. It's not supposed to. So when you are doing an ultrasound exam, you always look for placental cord insertion. That is, you know, we always look for that, and we always look for cord insertion into the fetal abdomen.
Yeah.
And we look at the fetal abdomen to rule out omphalocele, and gastroschisis happens right close to that. And the cord that inserts into the placenta. And when you see the two insertions, you're happy. But don't be happy quite yet, because sometimes there will be a succensurate lobe or a bilobed placenta. And if you miss diagnosing that succensurate lobe, the cord could be inserting into the placenta, but a blood vessel will go out of the placenta into the membrane and into the succensurate lobe or the bilobe. That blood vessel, the fetal artery and the fetal vein, both of them are going to go back and forth, and that could cover the cervical internal os, and you would have completely missed the diagnosis if you didn't go looking for that. So don't just be happy with placental cord insertion and fetal abdominal cord insertion. You need to look at the cervix.
Right. So, do you think it can be reliably diagnosed during an anatomy scan? Or, as you said, these are some of the sonographic signs which we shouldn't ignore and just say it's a accentuated lobe. We need to look at it more carefully. But do you think can these be picked up reliably at the anatomy scan? Or what are the one of the suspected factors would be are there anything else like that where we could pick them up early rather than late?
Absolutely. Yeah, absolutely. So, you know, the incidence of vasa previa is about 1 in 1,200 to 1 in 1,600. So it's pretty common. It's not an uncommon condition. And it's right up there in terms of causing deaths, the other conditions that cause fetal deaths. It's right up there with so many of the other conditions. So how do we do it? So at the anatomy examination, sure, you have looked at your cord, but after that, go down to your cervix internal os, look at it initially black and white to see if you see any bubbles. So those may be blood vessels that may be in cross section. Always put color on it. Always, always, always put color on it. And, you know, there are 3 different kinds of vasa previas. One is that the one that goes through one placenta to the succensurate lobe or the bilobe placenta. The other one that is easier to suspect is if the placental cord insertion is not in the placenta, it's velamentous.
Elemental.
So it's in the membrane, and you go searching and you can't see it anywhere in the placenta. And then you see, oh my God, this is up there in the membrane. But if it's down there in the membrane, the blood vessels have to go over the membranes and find its way to the placenta. There is no succensurate lobe. So that will make it easier for you to actually suspect that something, there could be a placenta vasa previa. Let me look for it. But even if everything is perfect, go look at your cervix midline longitudinal, where you can see that entire cervical length. Look at that, but not just that. You want to go to the right and you want to go to the left, because the blood vessel may be, 1-2 centimeters away from the internal os, or one on the left side or the right side. What I do is, so when you talk to Elise, he says, he looks at it longitudinally. Sure. What I do is I get a cross section suprapubic, and I look at the bladder, and the cervix is behind the bladder. This is mom's bladder, the cervix is behind. And I put my color, if need be, you can use power Doppler so you can get better colors, or you can just use black and white, but make sure that your colors are such that you have to know how to use colors, because if you turn your color off completely, you're not going to see anything. So your color has to be on proper.
Settings have to be right. Yeah.
Yeah, you have to properly, increase the gain and so on. And then you go cross section of the cervix from below the bladder, where the cervix is, go cross section, and then you'll come to the internal os. And if you see blood vessels, initially you'll see maternal because they're in the cervix. But when you go up, you might see blood vessels on cross section, and then comes the fetal presenting part. So if you see blood vessels, put your Doppler and listen to the heartbeat. If it's an artery, and often there's an artery, and if the heartbeat is 140, 150, it's not mom, it's a vasa previa. So you can even do cross section. And I always do cross section if I'm suspecting a vasa previa. If I'm not suspecting a vasa previa, the longitudinal, because, time and so on, longitudinal color Doppler, power Doppler, if it looks good, it's like, okay, let's go on to the next patient. But if you're suspecting vasa previa, always do that transverse section. So yes, you should be able to diagnose in anatomy scan. Why? Because anybody can have vasa previa. It just happens. And the three things that increase the risk of a vasa previa are IVF.
Right.
The second is, IVF. The second is if at 20 weeks, if your placenta was low lying, so less than 2 centimeters from the cervix, or if it was a previa. We know that placenta previas at 20 weeks, majority will resolve and go away.
Yeah.
But if it goes away, it might leave back a little blood vessel there. So if you have seen a low-lying placenta or a placenta previa, always look for the vasa previa at 32 weeks. Don't forget to look at it in the third trimester. Critically important, and especially if it's an IVF patient. And IVF patients, maybe they put that egg for, I'm not an IVF doctor, but I think that maybe when they put the embryo back in, the embryo is further down, not higher up where it should be. And that's why but IVFs have lots more placenta previas and vasa previas, a lot more. So those are your high risk factors, but everybody is at risk. So everybody should be scanned.
Can be at risk, but more so the IVF. Very important point that you've highlighted is don't be so happy that the placenta has moved away. In fact, look more for, a lot of times we just reassure and say, oh, placenta is no longer there. So the point you have said that if it's a low-lying placenta, we do call them to see if it is moved, but also to look for this vasa previa, which can be potentially dangerous. So yes, as you said, it has to be a transvaginal, isn't it, preferably? Or would you be able to recognize it as effectively in a transabdominal as well, do you think?
I think it depends on the expertise of the person. So, Dr. Sita, if you're scanning, I would trust you. When I scan, I used to tell my technicians, hey, I know what I'm doing, and I don't want the patient to go through transvaginal. But, as a universal rule, the Society of Maternal and Fetal Medicine, the SMFM, said no, you have to do a vaginal ultrasound at 32 weeks because many people are missing it. When you do it transabdominally, people are missing it. So, if 5% of people have worked for 30 years and have been looking at the cervix all their lives, they may be good at it, but majority of them are not there. So as a rule, so my technicians, actually, we have 23 technicians. We do lots of ultrasounds every day. And so they will tell me, no, Dr. Ritsinghani, I'm going to do transvaginal at 32 weeks because that is the rule. And then I said, okay, sure. Yep. SMFM says it, let's not break the rule. Yeah. So you must look at it in the third trimester because that vessel will sneak down. There's a third kind of vasa previa called the boomerang vasa previa, which is not velamentous and not bilobed. The cord is where it is, the placenta is where it is, but one of the blood vessels may sneak out, cover the cervix, and then sneak. It sort of loops. It's like a little free loop. Okay. And, you have to look for that also. So when scanning.
Yeah, it can sort of miss your eye if you don't look for it. Yeah. Right.
Yeah.
So can you walk us, because, explaining this to a family who are like completely, don't understand the implications, and just can you walk us through how do you counsel a family once you diagnose this, and should we scare them? Should we sort of make them prepared? Because especially IVF patients, the minute you tell them, they'll just go to bed and lie down and not move, which we don't want it either. So can you just help us, because counseling is always an issue with certain, vague topic subjects like this, where we can't make them understand the implications of such a dangerous complication if it happens. Yeah.
Totally. So, 15 years ago, I was scanning a radiologist. She was the chief radiologist at University of Iowa. She was 36 weeks. And at that time, I was just looking at the cervix because, just a habit, I transabdominally. And I saw the vasa previa. It had not been diagnosed. So I told her, I said, you have a vasa previa, and she's a radiologist. She's a professor at a university. And I said, a very senior, she was an older patient. And I said, I think we should do a C-section on you tomorrow. At that time, there were no protocols. Even today, there are no real proper protocols. But we do know that patients with vasa previa can go into labor early. We do know that. We do know that if patients have had a previous premature delivery, they can deliver early. So the protocol that we had a few years ago, I think 5, 6, 8 years ago, was everybody's offered admission between 28 and 32 weeks, and we let them choose. And then they sit there from 28 weeks until 36 weeks, and they used to hate it because, job and money and family and other children and so on. So Olesi actually he wrote recently, he's working with Shami. Shami was a student of mine. He is now the director of Fetal Care Center at Boston Children's Hospital and at Harvard. So the two of them are working now the studies are ongoing. So what is really the right thing to do? Nobody really knows. But they have come up with this protocol that if a patient has a very long cervix, and what is long? More than 2.5 centimeters. So if she has a long cervix, she's not going to go into premature labor. Her membranes are not going to break. So if she has a long cervix, don't admit her at 28 weeks because she could go into depression and get suicidal. So starting 28 weeks, check the length of the cervix, and it's a nice long cervix. Keep them outpatient, but at 32 weeks, they all get admitted. Right. Everybody gets admitted at 32 because for some reason, there's a higher chance for them to deliver prematurely. Mm-hmm. And then you don't deliver them until close to 36 weeks. So between 34, 36 weeks, when you take all the factors into consideration. So after 34 weeks, your threshold is low. But, what do you tell these patients? You tell the patients that you are so lucky that this has been diagnosed, because this is not uncommon. And this has been diagnosed prenatally, and nothing will happen to your baby. at least until close to 32 weeks, so do not worry about it. We tell them pelvic rest. So we tell them no sex, just because we don't know no study on it, but we just tell them don't disturb that area and just keep doing what you're doing, just nothing in the vaginal canal. And then by 32 weeks, we want to admit you. We'll admit you earlier if your cervix gets short, but not otherwise. And, and the fetal loss rate is so low, it's highly unlikely that anything bad will happen to your child. So please don't worry, because we have diagnosed it. Had we not diagnosed it, it would be a different thing. But we have diagnosed it, so don't worry about it. And most of the patients take it they're very calm about it.
Yeah, once you sort of counsel them and reassure them that we are with them, I think they feel, more at ease. So basically, as we're saying that training is an issue here, and how do we make sure that it can be improved so that especially in a country like ours where people working now with AI coming in and a lot of things improving our technology there, do you think how this can be improved to pick up so that the detection rates go up in India? And is AI being used here as well or in globally? Especially for Indian training centers, how do we think we can improve that so that this doesn't get missed?
So we don't use AI that much. We are trying to, my technicians are very resistant. And, we try to, AI they're using, like if they do a cross-section, sweep of the fetal brain, then you can get your cerebellum, your lateral ventricle, all the pictures can be pulled up. And so, instead of 7 minutes, in 3 minutes, you will have your BPD or all the pictures. So it helps shorten the test time, but it otherwise doesn't. You have to know what you're doing.
Absolutely.
And, I grew up without no AI, and I've been scanning for, over 30 years. And I do a lot of scanning. And I was taught by Dr. Roger Sanders. There's a Sanders textbook. He's the father of ultrasound. So he was the head at Johns Hopkins. So I used to, for 2 straight years, every single day, I would do ultrasounds with him all morning until lunchtime. So the thing is, I would not depend on AI to detect it. You have to learn. So just practice, and practice with somebody who is good at ultrasound, because that's the only way. I practiced my ultrasound with Dr. Sanders for 8 years. Even after I had finished my fellowship, I was a faculty there. I would still go to him every day and I would practice with him. And I realized that the first 8 years I was doing ultrasound, I really wasn't very good at it. And even back then, the machines were not good at all. But, I learned so much by just scanning and scanning and scanning. And you need to scan with some senior person who is good at what they're doing. Watch them. Watch and do, and then do. And so that's how you will learn. And the technique, 4 things you have to remember in the technique. One is, you can start with black and white picture, but be sure to put color. Otherwise, you're going to miss it. The second thing is, at 32 weeks, the patient had vasa previa at 20 weeks, and then again at 26 weeks, the vasa previa was documented, but at 32 weeks, the head is down there and you're doing a transvaginal and there's no blood vessel. You know what? It is there. It may be getting compressed by the head. So gently you can lift the baby's head transabdominally, lift it up so that there's fluid between the head and the cervix, and watch, because the blood vessels may be compressed for a few seconds and you may still not see it. So just watch, and then if it is there, you will see it. And if in any case that is suspicious, transvaginal exam is an absolute must. Repeating the ultrasound at 32 weeks is an absolute must for all low-lying placentas and all resolved previas. It's an absolute must. So if you do all of that, it'll be easy. And, sometimes, like I said, when the head is compressing, you may not see the blood vessel, especially if it is a vein, umbilical vein. But that vein, it may not fill up easy. And then when it does fill up and you try to do pulsation, there is no pulsation. And you might think it's a maternal vein, but it's a fetal vein. So go nearby. You will find an artery sitting naked nearby.
Yeah.
Or it might just be a venous blood vessel which is boomeranging, but you will see it is inside the membrane, not outside the membrane. So that requires expertise. So you need to just keep practicing.
Yeah. Yeah. And
Sorry, I'm coughing. I have to
no, that's all right.
wet my throat.
Yeah, so actually, we have our protocols from the SMFM, ISO-org. So you think this should be a part of a standardized antenatal protocol, isn't it, in terms of our...
Yes, it's a part of the protocol. And what I failed to mention is low-lying placenta is 2 centimeters away from the os. So even vasa previa does not have to be on the cervix.
Top of the cervix, yeah.
It can be 2 centimeters away. In fact, nobody really knows if it should be 2 or 3 or 4. What is dangerous? Nobody knows. And people are looking at it. So studies will be started. Shami and Olesi, they're getting people together. They're trying to do like an international group so they can figure out. But there was one case where the blood vessel was 2.8 centimeters away. And when the cervix opened up, the blood vessel was on there, they broke the water, baby died. So should it be 3 centimeters? So what Olesi and, they did a review paper 2 years ago, and I was listening to him recently. He was saying that, when the cervix dilates to 10 centimeters, the radius is 5 centimeters. So maybe we should use 5, but if you're going to use 5, you're going to be doing a lot of C-sections.
Yeah.
So, if somebody is gravida 8, para 7, and her vasa previa is 3.5 centimeters from the internal os, but it is velamentous, talk to her and then see what she wants and let her know the risks of C-section and the risks of not delivering her in a controlled fashion. So you will bring her in and you can deliver her at 37-ish weeks, 36, 37, give her steroids, and then you can actually deliver her and see how things are going. And if she starts to bleed or something happens, you think it's fetal, you can right away do a C-section. So maybe 2 centimeters is not the correct number. Maybe it should be more. But, people are looking at it, and with time we will. But so we are telling our patients, even if there's a naked vessel, even within 5 centimeters, we are telling them, if you break your water and the tear goes up to there, it's possible that it could be bad for your baby. So if you want a C-section, and some of these IVF patients who are, 40, 42 years old, they'll say, yes, section me.
Yeah.
But a multiparous patient will say, no, I'm coming in, break my water, my labor will last 10 minutes, I'll be done in 10. And that's fine. So between 2 and 5, you can, individualize the management.
Interesting. So we'll have to wait for more studies to come otherwise we'll be sort of over treating or over diagnosing rather. Because that's
Yes.
very subjective assessment of 2.53, and a lot will have to come in if you have to admit all of them from 32. That is also a huge burden for the hospital as well as the patient themselves. So
Yeah. And if she has had contractions or something, she may want to be admitted at 28 weeks, which is a bit too early because she has to stay pregnant until 34 to 36 weeks. But some people do want to get admitted at 28, and it's like, okay. So, it's short cervix, history of premature labor, premature delivery, PPROM, premature contractions. Sure, you can hospitalize them sooner. 28, 30 weeks should be fine.
Right. And so, as we're nearing the end of our, the podcast, I mean, there's so much to talk about, but there's a scarcity of time. How do you think simple improvements in ultrasound protocols can save lives in terms of, vasa previa or generally other stuff? What is your opinion on this? Because we do, in one end, we are talking about diagnosing the tympanic rings and looking at so much details, but whereas basic ultrasound, things that we shouldn't be missing can save these lives of these fetuses. What is your opinion and your advice on that?
Yeah, totally. So, we followed the SMFM 2015 guidelines, and in the SMFM 2015 guidelines, it says mid-trimester fetal ultrasound. Always look for cord insertion, always look for normal placentation, look for placenta previa, look for low-lying placenta, and look for vasa previa. If you see a vasa previa at your 20-week exam, perform a transvaginal at that time to confirm it. If it is low-lying placenta or a placenta previa, follow up at 32 weeks, and at 32 weeks perform a transvaginal examination. And if you do this, then in most cases, you will be catching it on time and you should not be missing it. So there was a small series where they had no fetal deaths. I guess there were 2 fetal deaths because the fetuses were anomalous or something,
Right.
but otherwise not related to vasa previa, where they followed this protocol. And so, protocols are changing. I mean, even 5, 6, 7 years ago, we were just admitting them because somebody put that protocol, admit them at 28 weeks. So we all were admitting them at 28. And then we saw too many people getting depressed, expensive, so on. And then we changed it. So now, not only cervical length, I forgot to mention, starting 30 weeks, because the blood vessel is down, and if the baby's head keeps pushing it, you'll see a little variable deceleration every time the baby moves. You'll see a tiny variable deceleration lasting maybe 15, 20 seconds. So, we actually monitor all patients on a weekly basis, fetal heart rate monitoring, to look at the heart, fetal heart rate, as well as for contractions, because some people don't feel contractions. So we monitor them, and if she's contracting every 4 minutes, not even knowing it, then we want to admit her.
One
But
important point
practice
that you
is the
mentioned.
only way to do it, is just keep practicing, and it should be the
Perfect.
standard of care.
Yeah. Yeah, very important. Practice makes a man perfect. But one important thing that you alluded to earlier in the podcast is the role of placental histology and not discard these placentas. Because as you said, the pathologist should also know. So how can we sort of, because a lot of time, even for the preeclamptic placentas, if we send, we just get the report, it's placenta. I mean, we know that, we want more information. So that one message from there regarding the placental histology, which we should be sending and looking at the placenta after it's delivered, isn't it? Because most of these stillbirths are born in the middle of the night where no seniors are around. They just discard the placenta. So your, advice on that, your
If there's ever a stillbirth, make sure you're looking at the placenta properly, not just the cord insertion, but look at the entire membrane and look at the edges of the membrane where the water was broken, where the membranes were ruptured, because you might find a blood vessel right at the edge of the membrane. And when you're sending the placenta to pathology, when we send it to our pathologist, we have a space up there, and it's all computerized and it's all typed out. So they can't say that they don't understand our handwriting. But there we say, stillbirth, blood vessels seen at the edge of membrane, please rule out vasa previa. Then they will look at it properly. But you have to give them a heads up. And the reason also is some hospitals, they send all the placentas to pathology, which is dumb. If you have 5,000 deliveries in a year, the pathologists hate to look at placentas. They want to see so many. So you have to bring it to their attention. In some places, they have pathologists that specialize in placental pathology. Dr. Sunil, he's very good at placentas. He was in Lucknow and now he's in Michigan. He is brilliant with
Perfect.
placentas, and he
Yeah,
sees
yeah,
so many things that nobody would even ever think of. But so
yeah. It's
you
a
need
new.
somebody interested in placenta.
True, true. But it's
But
as you said, the equally the communication between the obstetrician and the pathologist, that what we're looking for. Otherwise, it's just a piece of tissue for them unless we are told what to look. So yeah, one last piece of advice for you for the budding fetal medicine specialists about and the obstetricians as well about how we can about this decoding stillbirth and how we should be aware and prevent and predict.
predict and prevent vasa previa related stillbirths.
Yes, and generally in terms of stillbirths as well.
Stillbirth, I mean, there are so many stillbirths that occur in patients where they don't even come for good care. And, they may be hypertensive, they may be diabetic, they may have renal failure. I remember seeing a patient with cholestasis in Lucknow when I was there recently. And so she was 38 weeks, miserable. She was scratching her palms and her sole, terrible. And so we told her that it was very obvious she had cholestasis. And she was sent for an ultrasound. And I did her ultrasound because I went to somebody's office and they asked me to come and, hands-on teach them. And I'm happy to do it. It's my hobby. So we tried to explain to the husband and to the patient that you're 38 weeks. It looks like you have pretty severe cholestasis because she had some lab abnormality. Somebody had done some lab on her. I think her LFTs were elevated. But when the doctor called her the next day, or wherever, I don't know how the communication happened, she had not gone to labor and delivery. She didn't go to see her doctor. She was at home. And so if she's at home with such severe cholestasis, she's risking fetal death, which is 7 to 10%. But so, patient has to partner with you.
Yeah.
You can do the best, but if the patient is not your partner, there's nothing you can do about it. And I know from first-hand experience, some relative who had low-lying placenta, and I said, who's still pregnant? I said, be sure that you get a repeat ultrasound. And she's 40 years old, 40, 41. And she said, I'm not high risk. Please don't try to scare me. So what do you do? So patient has to be your partner. You have to do due diligence, but also tell the patient, you are my partner, and we both have to take care of the pregnancy. If you don't help me, I cannot help you.
Alone, yeah.
And so you just have to be very, very diligent and hopefully reduce stillbirths. But, some stillbirths will occur no matter what.
Yeah,
And you just don't know why it happens.
Yeah, science is never 100% or 0%. So we still have to make it as much as we can. So yeah. So thank you for that. Any parting words? And I think we will end this podcast. Any parting words from your side?
No, just keep practicing and, fall in love with ultrasound. I'm, like Dr. Sita, we are both in love with ultrasound.
Absolutely.
And it's my total passion. And I would never think of retiring because, I have been scanning for many years and there are so many mysteries. And I'm seeing younger doctors. We have 13 high-risk OB doctors where I work. And the younger doctors, if it's 5:30, they want to go home. They don't go into rooms. They don't scan. To them, it's important that they go home to their family. They have dinner. If you do that, you're not going to learn. And, I try to teach them because I do sort of take little classes with them. But as soon as they'll say, we have to go home, Dr. Singhani, like, okay, fine. These are full-fledged MFM United States American. I work, all my colleagues are American, like regular, mostly white, and 2 of them are Black Americans, but they're Americans. So you have to be very compulsive about practicing.
Passionate
You
about
don't practice, you won't learn.
Yeah.
Right, Dr. Sita?
Absolutely. And as you said, even if you've done your so-called, the more you do it on your patients, it's the learning on your patients as well. And that learning just continues. It never ends. So there's so many
Totally.
things we learn even today. And it's amazing how much the ultrasound and the fetus can offer you and can show you. It's only for us to be there and see it for ourselves. Yeah. So thank you once again
And
for,
it's so exciting. It's so
yes,
exciting.
it
It's
is.
like a hobby. And I tell them, it's my hobby. And why are you guys paying me all this money? Because I'm going for my fun. But you get paid for doing fun. So it's like, okay,
It's nice that we get to enjoy what we're doing, and I think that's what is
yes.
important. You need to enjoy what you're doing. So thank you, Dr. Asha Ritsingani, for that beautiful and was very informative. I think it's a need of the hour where we understand about this very important cause of stillbirth and pick it up as maternal fetal medicine specialists and do our best to reduce the incidence of stillbirths in India and across the world globally. Thank you once again for your time.
Thank you so much for having me. What a pleasure.
It
I
was.
really admire you and I admire Bhaskar, lovely couple. And I'm looking forward to seeing all of you in January.
Yes, please. We are waiting to welcome you as well. So thank you once again. Thank you.
Thank you. Thank
Bye-bye.
you. Bye bye.